In this capture, we're going to review some very basic respiratory disorders. We'll begin with sleep apnea, most often termed obstructive sleep apnea or OSA. With OSA, there are recurrent episodes of airway obstruction, and this causes a reduction in ventilation. So with the reduction in ventilation, you have impaired gas exchange. So you're going to have somebody who's not having enough oxygen in the blood. Because this is sleep apnea, this generally occurs while the patient is sleeping, and it can be very much related to positioning as well as obesity, so excess tissue, particularly in the neck area. So symptoms of OSA, you'll find excessive daytime sleepiness, so people being fatigued a lot, falling asleep during the day, waking up frequently at night, loud snoring, and AM headaches, particularly on awakening. Those are all pretty classic signs of OSA. Okay, so what's the big deal? Well, OSA increases the risk for hypertension. It increases the risk for cardiac dysrhythmias because of the lack of oxygen in the blood during the time of sleep. It also long-term leads to a risk of what we call pulmonary hypertension or cor pulmonale, which relates to right-sided heart failure. So treatment for OSA typically is going to involve CPAP. Again, this is a machine, a face mask, a nasal pillow that the patient wears at night while they're sleeping. It basically helps keep that airway open, makes it a little bit easier for them to be taking breaths, not having episodes of this sleep apnea. BiPAP and oxygen therapy might also be used. Also, there are some options for surgery, particularly if the obstruction is related to the tonsils and the adenoids. They may consider doing a surgery to remove those. If you haven't done so already, make sure you check out the Picmonic on OSA. It's available on Lippincott in Chapter 22. It really does kind of show a nice animation and hits the very key points of OSA. With upper respiratory infections, these are things that are commonly treated more so in community settings. We don't typically see hospitalized patients just with an upper respiratory infection. So you see these patients, doctor's offices, urgent care. You will see them in long-term care facilities because, again, that is their home. Signs and symptoms: headache, cough, hoarseness, fever, that congestion, generalized discomfort or malaise, and the allergy type symptoms. So upper respiratory infection, or URI, is kind of a big blanket term. There are a lot of different sub-diseases, sub-disorders. Rhinitis, rhinosinusitis, if it's not just the nose, it involves the sinuses. Pharyngitis, laryngitis, if it involves the pharynx and the larynx. And you can also develop what we call peritonsillar abscess. So for the most part, upper respiratory infections are very minor. They're things that we deal with. But there are some potential complications that if it's not clearing up easily, it's not clearing up. You can have issues with airway obstruction. You can have issues with bleeding. In severe cases, it can progress to sepsis. We worry about meningitis and brain abscess, particularly with the sinusitis piece of it, because you're right up there in the head. Otitis media, you can have development of an ear infection, some swallowing issues, some voice issues, losing your voice, not being able to speak. And then, of course, cellulitis, so having that infection progress into the tissue. So just some basic things with rhinitis and rhinosinusitis. You can see they both involve inflammation, irritation of the mucous membranes. With rhinitis, it's in the nose. With rhinosinusitis, I have it in the nose, but it's also in the sinus cavity as well. And basically it becomes congested and that sinus secretions cannot drain out. So they're just kind of sitting in there. And you can see in the picture on the screen where that woman's face, her eye is essentially, swelled shut because of the issue in the sinuses. Okay. With just the nose piece, the rhinitis, it can be acute versus chronic. It can be allergic okay, which these are just allergic symptoms that is causing the rhinitis. Or it can be non-allergic. Usually that's viral related, your common cold. With rhinosinusitis, we get concerned because if it's viral, your body's going to fight it on its own. But if it's bacterial, it may require some antibiotics. So if it's gotten to the point where we're looking at sinusitis, they will often treat this with an antibiotic, just because we don't want any type of bacteria progressing further and causing like a meningitis. So some general interventions for upper respiratory infection, regardless of the type. Certainly elevating the head, that's going to help with respirations. It's also going to help with sinus drainage, okay? Because as much as nasty as it is, runny nose, we really want that drainage out. It's better out than in. Humidifiers, breathing in the steamy air from a hot shower, again, helping to open up those nasal passages, help with the drainage of those secretions. We can use analgesics like Tylenol, ibuprofen for pain, gargles for the sore throat. This can be water, salt water, it tends to be helpful. If they have some laryngitis in there, they can't speak, you have to obviously have some sort of alternative communication. Certainly, disease transmission is always a concern, even for something as minor as upper respiratory infection. We still want to make sure patients are using appropriate cough etiquette. They're coughing into their sleeve versus coughing into their hand, making sure they're disposing their tissues appropriately, washing their hands, using hand sanitizer. Again, we want to encourage liquids. Again, increase those 2 to 3 liters a day unless it's contraindicated. If your patient has a history of heart failure, there's no way we can get them to 3 liters a day. You might not even be able to get them to 2 liters a day if they have a significant history of heart failure. But again, as much as possible, we want to hydrate them to try to loosen those secretions. Soft, bland diet, especially if they have a sore throat. We do want to make sure they're taking in nutrition. Rest. They really need to rest 8 to 10 hours a day. They may not be able to do that all at once, but rest periods throughout the day. And then, of course, patient education is important. I mentioned hand hygiene before. I've mentioned prevention strategies before, flu vaccine, pneumococcal vaccine. But the other big piece of patient education is if they are prescribed antibiotics, to make sure they are taking them as prescribed and taking them on time and they finish the entire prescription. Looking at the flu is a viral infection. When you hear about people dying from the flu, they typically developed a secondary infection, a bacterial infection, bacterial pneumonia. And generally it's not the flu that killed them, it's actually the secondary pneumonia that developed. So when you hear about flu-related deaths, it's because of this complication. So the flu is spread by coughing and sneezing. Okay, so it enters via the mucous membranes, your nose, your mouth, your eyes. Okay, this is why it's important, hand hygiene, not touching your face. Flu patients are going to be in droplet and contact isolation. Symptoms that they might experience, your typical fever and chills. They often have a cough, sore throat, headache. They tend to have a lot of myalgia, just that they ache all over. They feel miserable. They're very fatigued. Some flus will also present with GI symptoms, diarrhea in particular, sometimes some nausea, vomiting. But that's not all the time. Really, when we think about the flu, we want to focus on prevention. Because once a patient has the flu, we do have some antiviral medications that we can use, but they are most effective if they are started within 48 hours of symptom onset. A lot of times that's not the case, so our care is going to be very supportive. Hydration, oxygenation, just basically supporting their body functioning. So with the flu, we really do want to focus on prevention. So again, the hand hygiene, the cough etiquette, avoiding large gatherings, particularly during flu season, close contacts, vaccination. But really, the best thing you can do to help prevent the flu and really prevent illness in general is to really foster a strong immune system. So taking care of your immune system with good nutrition, adequate hydration, adequate sleep and rest, really trying to maximize your body functioning. As I mentioned before, typically your care is going to be supportive. We're going to be doing supplemental oxygenation. If they require secretion management with suctioning, we'll do that, focusing on hydration. Comfort, we can use saline gargles. We can use things like acetaminophen for the discomfort as well as to manage a fever. Although that's a little bit controversial as well too, because the reality is your body, that fever is part of your body's immune response. And it does that because bacteria and viruses don't replicate as well in warmer environments. So it's your body's way of fighting the infection, of trying to slow everything down. So with regard to treating a fever, it really depends on the patient. If your patient is absolutely miserable, they're not taking in fluids, we're having to do IV hydration, okay, let's go ahead and give that acetaminophen. If it's tolerable for them, unless that fever gets really, really high, and I'm talking like 104, it may not be worth treating that fever. Because again, that's going to slow down the body's own response to that virus. As I mentioned before, there are antiviral medications. They're helpful if started within 48 hours of symptom onset. The one you're probably most familiar with is Tamiflu. That is given PO. It does cause GI upset, so it must be given with food. Recently, there's been some research and reports that have come out that kids can sometimes develop some psychotic symptoms and hallucinations and that with Tamiflu. You'll probably talk a little bit more about that when you get to your peds class, but just something to consider. You can also see those effects in adults, but they seem to be more common with children. And then, of course, there's Relenza. This is a dry powder for inhalation. I don't see this used as much anymore. Typically for the flu, we're using the Tamiflu. So some other common medications to cover in relation to respiratory disorders, and these are part of your pre-class prep. Decongestants, which will help kind of minimize that congestion, kind of reduce that swelling, again, facilitate that secretion drainage. Antitussives really suppress a cough, while expectorants will actually encourage the cough. Those are very effective and helpful for patients that have a moist cough, where we want to get those secretions out. Of course, antibiotics, we mentioned those before. Antihistamines, very helpful with rhinitis, particularly allergic rhinitis. And there are two generations of antihistamines. You have your old school ones, your Benadryl. Those tend to have drowsiness as a significant side effect, whereas your newer generations, your loratadine, your Claritin, your sertraline, your Zyrtec, those you're getting the antihistamine effect without the drowsiness. We also have bronchodilators, which do exactly what they sound like. They help dilate the bronchi, the bronchioles. You have your albuterol, which is more short-acting, and your ipratropium, tiotropium. Those are your more long-acting maintenance medications. And then, of course, we have corticosteroids. Steroids are all about reducing inflammation. They are available in a variety of forms. So there are nasal corticosteroids, Flonase nasal spray. They have inhaled corticosteroids, your meter dose inhalers, your dry powder inhalers, nebulizers. It also comes in a PO form and IV form. Now, the PO and the IV, those are generally used for short-term problems, exacerbations. It's your nasal and your inhaled ones that are more your long-term, your maintenance medications. So switching to tuberculosis, and, for a long time, we had really thought we eradicated TB. And starting like in the 90s, it really kind of reared its ugly head again. It's kind of, had a resurgence. And there have been cases of what we call a drug-resistant TB. And that's pretty dangerous because with those patients, they're carrying this around and they can spread it if they have an active TB. And if they're drug-resistant, it's very, very difficult to treat. even treatment for non-drug resistant, we are going to treat it as if it is drug resistant just because we don't want that resistance to develop. So symptoms of tuberculosis, these patients will often exhibit a low-grade fever. They will have a persistent cough, and it will be a productive cough. It'll be like a mucopurulent sputum. So it'll be, kind of a thick, nasty sputum. They will have blood in their sputum as well. They often experience night sweats, fatigue, and weight loss. Very important for you to understand, this is airborne transmission. So when you have a patient come into the hospital with a diagnosis of TB, or we are ruling out TB, they're going to be put in airborne isolation. So if you remember airborne isolation, you're not just using a regular surgical mask, you're using an N95 respirator, okay, because that's going to filter out tinier particles. And they are also placed in a negative pressure room. And if you think back to foundations, what that means is when somebody's in a negative pressure room, when the door opens to that room, the negative pressure is inside the room. So it sucks air into the room. So air from the hallway gets sucked into the room. You go in, you close the door. Okay? It does not allow air from inside the room to go outside of the room. So that's very important for you to understand. Testing for TB, there's a couple different ways that we can do that. They actually do have a blood test now. It's called the QuantiFERON Gold. What is nice about that, it detects both latent and active TB. It's done through a blood draw. It's fairly easy. It is rather expensive though, so you're not necessarily seeing this used very widely. Chest x-ray, we're definitely looking to either rule out an active TB or show that there is some sort of active pulmonary disease. Chest x-rays are done on anybody who has had a positive MAN2 test in the past, because the MAN2 test basically just looks to see if a person has been exposed to TB and if their body has developed antibodies. Okay, so this is the one that you probably got when you came into the program, and you get your two-step PPD and you get your annual PPD. But it is a little bit of the TB extract, and it's administered intradermally, usually in your forearm, and you have to get your results read in 48 to 72 hours. Now, something that a lot of people don't know, when you look at the site where you've received that MAN2 test, it's not just on what it looks like. Okay, the actual results and how you evaluate it is based on induration, so firmness around that area of injection. So it may look perfectly fine, there's nothing raised up, but that's why the nurse always palpates over it to see, is there induration. So typically in a healthy person who's not on immunosuppressants, that induration would have to be at least 10 millimeters to be considered a positive test. If you have somebody who is immunocompromised, their cutoff is going to be 5 millimeters. Again, that result has to be read within 48 to 72 hours. Again, that positive test just indicates that the body was exposed at some point and mounted an immune response. It does not confirm active disease. Okay, it does not confirm active disease. If somebody is exposed, it usually takes 2 to 10 weeks to develop that immune response. The other test that we will do to confirm and rule out tuberculosis is what we call a sputum AFB. The AFB stands for acid-fast bacilli, which is the type of bacteria, the classification of bacteria that causes tuberculosis. So here, it's not just the sputum culture, but actually they're doing a sputum smear, and we're looking for these specific types of bacteria. So managing TB, again, we go back to our general interventions. Pulmonary hygiene, we're trying to maintain the airway clearance, we're promoting gas exchange. A big piece of what we're going to do is limit and preventing transmission. Okay? We really do not want this spreading to other people. Hydration, nutrition is very important. And the other key piece is really advocating and ensuring adherence to the treatment regimen. Remember I mentioned before, we've had the resurgence of TB and the development of multi-drug resistant TB. So, because of that, patients are treated usually with at least 2, sometimes 3 to 4 different medications in order to treat the TB and completely eradicate it. So they're on multiple medications, and they're usually on them for weeks, sometimes even up to several months. So it's very, very important that they adhere to that treatment regimen. And because of the risk of transmission to other people, we want to verify this by direct observation. So patients with active TB being treated at home, they're going to be monitored by the health department because they essentially are going to be quarantined. They are not permitted to leave their house, and they will set up some sort of direct observation for them to be able to take their medications, so the health department can verify that they're doing that. In today's world, with technology such as Skype, Zoom, that sort of thing, GoToMeeting, we're able to do that a lot easier than we did in the old days. But adhering to the treatment regimen is going to be critical, just because of the fact that the treatment is long-term and it involves multiple medications. We're going to take a look at some of these medications a little bit more in depth, but the meds themselves, they cause side effects. They're not fun, but it is critical that they take them as prescribed and they finish the entire treatment regimen to eradicate this TB, not spread it to others, and try to minimize the development of further drug resistance. So looking at INH, this is probably one of the mainstream things that we are going to use. Adverse effects, anemia because it affects the blood cell production, but we really get concerned with peripheral neuropathy, hepatotoxicity, so causing damage to the liver, and also optic neuritis, which can actually cause, vision blindness. Okay, so in treating patients with TB over the years, they have discovered some things that we can do to kind of help. But the reality is, if the patient has experienced these things, they can alter their drug regimen, but we still have to look at treating that TB. So we do know that vitamin B6 supplements given with INH is helpful in preventing the neuropathy. So we definitely want them on vitamin B6 supplements. We definitely want to assess them and monitor for that numbness and tingling of the hands and feet. We want to teach them to report if those things are starting to occur. This particular medication needs to be taken on an empty stomach for best effectiveness. Okay, so that's an important point. In relation to the risk of the hepatotoxicity, we want to avoid anything that's really going to tax the liver. So alcohol, acetaminophen is generally not used with these patients. And of course, we want to monitor for any signs that there might be liver issues developing. So jaundice, dark urine, excessive itching on the skin. And they're going to have periodic blood work checking those liver function tests. Rifampin is also commonly used. Biggest adverse effect of this is the hepatotoxicity. So again, the same things we were doing with the INH. Nursing implications, it will turn the urine and secretions orange. You need to tell your patient this. That can be very alarming, but that is an expected thing with rifampin. Again, we talked about the liver stuff. Other things you want to watch for is pain and swelling in the joints. And this medication will definitely interfere with the efficacy of oral contraceptives. So patients need to know that if they're on the pill, they need to be using a backup form of birth control. With your PZA, again, you're seeing a lot of the same adverse effects. It's all about the liver. With this drug, you can see hyperuricemia, which puts them at risk for gout, and also some GI disturbances. So as you're looking at these adverse effects, you can see how it would be very easy for these patients to decide, well, I don't want to take this medication anymore. I just can't take the side effects. This is really critical that they do adhere to that treatment regimen. So this particular med, they need to increase their overall fluid intake. Anytime they're taking a dose, they have to take a full glass of water. Again, really watching those liver things. Um, and the last one, our EMB. This one is not generally a first line treatment. This one they kind of reserve um, if a patient is not showing improvement with the other ones. This one can develop optic neuritis, so it's very important they have a baseline visual acuity and a color discrimination exam, and they need to be taught to immediately report any changes in their vision. And this is generally not used for anyone under the age of 13. Streptomycin is also a medication that may be used, but again, that one has some pretty significant side effects, so that is not a first-line treatment. Unless these things are not working, then they may add that on there. Switching gears to a different problem, epistaxis, or basically hemorrhage from the nose. It's usually from the anterior septum, and the issue with this is because it can cause airway compromise. If they aspirate that blood, it's going to affect their gas exchange, their airway, or it can cause significant blood loss in severe cases, and then we're looking at a hypovolemic shock. So medical management, you actually want to have the patient sit forward, kind of tilt their head forward. We never want them to tilt their head back because that can put the blood down into their airway. So they need to sit forward, pinch the soft portion of the nose for about 5 to 10 minutes, and hopefully that pressure will cause that blood to clot. There are some sprays that we can use, the phenylphrin spray. This causes vasoconstriction in an attempt to get the bleeding to stop. In severe cases, it can be cauterized. We can use silver nitrate. They can use electrocautery to get the bleeding to stop. A lot of times they will pack the nose. They'll put gauze packing up there into the nasal cavity, and it will stay into place like 3 to 4 days. It sounds weird, but it almost looks like they have tampons in their nose. And actually, you really could use a tampon in a worst case scenario, but really trying to put that pressure on there. In some cases, they can actually use a balloon inflated catheter. So you can kind of see that from the pictures on the screen. Typically, those are left in place 3 to 4 days. Again, we want to achieve hemostasis and kind of avoid having it rebleed. So once we get things to stop, they need to avoid any type of nasal trauma. They cannot be picking their nose. We see this a lot with kids that have nosebleeds. It's because they were picking up their nose. So we want to avoid any type of forceful blowing, no spicy foods, tobacco, excessive exercise, anything that's going to cause an increase in the airflow through the nose, because that can dislodge those very gentle clots that are there that are stopping the bleeding. The other thing that's very important from a preventative aspect is really to make sure you're ensuring adequate humidification. This is why if your patient's receiving oxygen therapy, we always say if they're at 4 liters or higher, they must have humidification. That's a must. That's part of the policy, part of the protocol. But even if they're on low levels of oxygen, 1 to 2 liters, that excessively dries out their nasal membranes. So it's appropriate to use humidification with them as well. But even patients that aren't on oxygen therapy may really benefit from using a humidifier in the home, particularly in the wintertime. If you're using electric heat or you're using wood or coal heat, it really dries the air out. So having a humidifier can be very helpful. Finally, we're going to kind of wrap up with the cancers. And again, I'm not going to hit these too heavily because Unit 6 has an entire piece where we really get into cancer concepts as a whole. So just to kind of hit a little bit about laryngeal cancer, this is about half of all head and neck cancers. Early signs and symptoms are the hoarseness, persistent cough, okay? Hoarseness, persistent cough, and a raspy voice. So you think about those things, you're like, wow, well, that kind of really hits how many different respiratory disorders, how many upper respiratory things. Because it is so non-specific, this is why a lot of times patients will not be diagnosed until they're having later signs and symptoms. And by that point, the cancer has, grown more and perhaps has spread both regionally and maybe even metastasized. So later signs and symptoms, the difficulty swallowing, shortness of breath, foul breath, just general debilitation because they will have significantly lost weight. Diagnosis is going to be based on a laryngoscopy. Sorry about that. Basically, they're just going down with a tube with a camera on it, and usually at that point they can visualize the presence of a growth there. They can take a biopsy. I have TNM staging up there. Basically, for now, I just want you to understand that's how they're going to determine is it cancer, and how severe the cancer it is. That's how they're going to stage it based on the size of the tumor, if there's lymph nodes involved, and if there's metastasis. Surgery is usually the typical treatment. Radiation and chemotherapy can also be used. Big focuses for these patients are going to be airway management because we worry about that growth obstructing the airway. Nutrition is going to be important because, again, they have difficulty swallowing. Plus, those cancer cells are dividing so rapidly that it is using a lot of the body's nutrition. So this patient's already going to be malnourished. And then certainly with surgical treatment, that's going to affect their ability to communicate verbally. And the scars is going to cause some psychosocial concerns. Lung cancer, again, just hitting the highlights of this. Typically, it's going to be classified as non-small cell or small cell. Common symptom is going to be cough, and especially a cough that has changed. Now, we know that smoking is a major risk factor for lung cancer, and smokers often have that smoker's cough. So again, many times until this is resulting in significant shortness of breath and it's really impairing their everyday life, they may not necessarily seek treatment for it. That then in turn causes lung cancer to be diagnosed in later stages. So chest x-ray will show a mass, it will show a growth. The CT is probably going to show the same thing. The bronchoscopy is going to provide the direct visualization of the growth and allow for biopsy. Again, as I mentioned on the previous slide, treatment is going to depend on staging. This lung cancer is a lot of times diagnosed late stage. If they're doing surgery, it can vary from removing the entire lung, removing a lobe, removing a certain segment or a wedge, chemotherapy, radiation. A lot of your lung cancer patients are using these things for palliative care. They may require thoracentesis to drain fluid that builds up as a result of the malignant cells. But a lot of times when we're looking at palliation, we're looking at pain management and a hospice referral.